in 1986. We started in 1986 with treatment, therapeutic community. Then we have been doing harm reduction work with the mobile methadone, also with the transitional flats. We have also a project of supported employment. We run a drug and alcohol consumption room and a health care program in a shelter, in a municipal shelter. And also we run this drug consumption room where we are now. We would like to start by saying that over the last more than 30 years, we have been developing an health and social care model, and this is our model. So in all of our projects, since the therapeutic community to the drug consumption room, mobile methadone, in almost all of our projects, we work like this. So we have a first contact, or the clients have a first contact with some case manager in the team. We provide also medical appointment screening for the main infections, methadone, medication for the main infections, and also psychiatric medication. We also provide contraception and vaccines. We work on monitoring all the health condition of our clients. We provide transport to connect to the system. And we work with very close with all the partners in the system, social and health care system. Migrants, women, and gender issues are the challenges that we are dealing now, and we are trying to adapt our services to these groups. So the mobile methadone van started in 1997. It's a methadone van for people who use drugs, but for people who have addiction to opioids. So we have usually 1,200 clients every day in our mobile vans. The profile of our users are people in high-risk behaviors with personal disorganization, physical impairment or disease, psychiatric disease, and mostly people in vulnerability and social exclusion condition. This is a very low threshold or low barrier, very accessible program. So it's very easy to come to this program. We don't put many barriers. We just need to check through urine analysis if someone is taking opioids. And then we try to give what the client is asking. So we try to understand, first of all, if this is the right place to be, if the profile of the client is to be in a mobile methadone. But if so, if the team evaluate this is the right place, all the admission procedures are very simplified. Our main concern is towards the abstinence symptoms and craving, and we will provide a lot of services regarding the screening and healthcare. It's not required to stay out of drugs, so it's very important. So it's a low threshold program. So another main low threshold intervention is the one that we are doing in the drug consumption room. Here you can see that it's an integrated support service. So it's not only a room to come and use drugs, it's an integrated service. So we provide many other services and not only the place to use drugs. So the history of this place started in 2001. Well, with the decriminalization law, it was already possible to have drug consumption rooms, but for many reasons, we could open only 20 years after. And the first project was to open one mobile and two fixed DCRs in Lisbon. Our fixed facility, it was the first in Portugal, opened in May 2021. It was funded by the City Council during the first 2 years, and then since then it's co-funded by the ICAD, which is the National Institute of Drugs and Drug Addiction, and also in 20% by the Lisbon City Council. So the process started with a social diagnosis around 2016, and then we choose a location. we created a monitoring committee. We had lots of meetings with partners, organizations, and then at some point in this process, the community around in this neighborhood, and I will show you some photos where are we of this specific reality. At some point, the community asked to the city council to be listened, because they were not against to place a DCR in their neighborhood, but they think that there was some priorities before the opening of DCR. And for example, this is a neighborhood not in the center of the city, so they couldn't have a bus passing inside of the neighborhood to connect to the schools, for example, nearby. They had some temporary water supply system, so it wasn't working very good. So, and after some of these basic needs being solved, we could open the DCR. So fortunately, the city council listened to the requests, and they provided what was really missing in this neighborhood, and then we could open with no problem. So this is where we are. We are not in the center city. The center city is like where you see the word Chiado. So we are not over there. We are a little bit out of the main urban area. And I'm telling this because this is very important. We are in a very specific setting. So this is a neighborhood that was known since the beginning of the 1900s. A place where you could see a lot of poverty and misery around. And from the 50s of the 1950s, we could see the increase of illicit activities. So mostly since the 80s, late 80s, we could see a big open scene of drug use with a lot of thousands of people coming here every day to use drugs in a big open scene. So it's not the same anymore, but it's still a place where we can see this. So it's drug trafficking activities happening all day. A lot of drug use happening in public spaces, people with deficient personal care at all levels, some major public health risks, and a lot of social exclusion and stigma. So this is where we work. These are the package of our main objectives. So to promote the dignity and social inclusion, to promote health education and safer drug use, to enable the linkage to care and treatments, to promote the screening and treatment for diseases, and to promote urban hygiene and reduce the public health risk and social noise. So that's why this is an integrated service. So we have showers for people, we have place for people to eat something. We have occupational activities, screening for the main infections, nursing care, medical care, and hepatitis C decentralized appointments happening here every week. Lots of people doing medication for chronic diseases, or for infections like HIV or hepatitis C, even psychiatric diseases. So, and this is the description of our admission procedures. So anyone can come. All of them have to be above the limit, the legal age, so more than 18. We don't ask for ID. So here we can say that, okay, but how do you know that people have more than 18? When we have doubts, we ask for a proof. Otherwise, we don't put that barrier. At the first contact, we need a simple registration. We try to understand who is the client. Everything is confidential. people need to use drugs to come to us. So that's why we do a simple evaluation. All the people have to sign a consent form allowing the intervention, for example, when they need the basic life support. There's no barriers about substance, and this is a low threshold service. It's very client-centered. So this is the map of the plan of our drug consumption room. So the entrance is where you can see the green arrow. There's a reception. There's also a place to leave the pets and where people can smoke cigarettes and also hashish, marijuana. All the people have to say in the reception what they are coming for. So they can be just having a coffee or coming for a shower or coming to use drugs or coming to an appointment, anything. So, and when in the reception, when they allow people to go to the left, where the drug consumption rooms are, people can come, and we have one intravenous room with 8 places to use, and we have now 2 smoking rooms with 18 places in total. They are all supervised rooms, so we have 2 nurses and 2 educators working in this area. This is the picture of a regular day. So almost 300 entrances in a place, which correspond to 170 in average, 170 unique people, 240 consumption produced every day, 90 snacks provided, 5 social appointments, 12 showers, 4 medical appointments, and 80 nursing acts. So you can see on your right that since the beginning, since we opened, we had a lot of work. More than 3,000 clients are registered, mainly smoking. There's a curiosity. 1/3 of these clients are or were in a OAT program, like methadone, for example. This is a multidisciplinary team, so you can see some of our staff members. We have nurses, a psychiatrist, a GP doctor, clinic staff, social workers, volunteers, educators, and a psychologist. So this is the distribution around the room, just for you to better understand how we distribute. Okay, so some information about substances used here. In the smoking room, it's a bit more prevalent right now. In the beginning, it was the difference was huge from smoking to injection. Now it's not, it's more balanced. So the rooms are balanced. The most used substance here you can see in the smoking room, it's heroin and crack mixed. In the injection room, it's definitely the speedball or heroin and crack mixed that people use in more. So this is the distribution since we opened. So in green, you can see the smoke consumption. Here you can see that last year we had a big increase because since the beginning, we had only 1 smoking room with 6 places. And then since the last June, I think June 2024, we had the possibility to open a new smoking room with 12 more places. And here you can see that those places are being used a lot. So in terms of drug checking, we don't provide drug checking by our own, but we have a protocol with another institution that come here once a month and do the screening, the checking for the drugs. Since we have opened, 62 overdoses happened, 51 inside and 11 nearby the drug consumption room. Yeah, all reverted. So 62 non-fatal overdoses. And this is the profile of our clients. So mostly men, 85%, with an average age around 45 years old, mostly coming from Portugal, but the second income country or continent is Asia. We have an increase of people coming from India and Nepal. And we have some challenges, but we also can talk about later. But we have some difficulties, some challenges related to also with the moment that we are living here in Portugal. Since I think that it's becoming more serious since 2 or 3 years ago, that we have now more pressure on the services, more people using drugs, or it's now more visible again, the phenomenon of small open scenes around the city and around this neighborhood, which means that there are more people using drugs. Well, and that this is a challenge because we need more places like this one to provide this service. So this is it. We can talk about later. Thank you for your attention, and now we are at your disposal for some question.
Hugo, thank you so much. I really, we all really appreciate this. And I neglected initially to say that Tess was key in helping us connect to Hugo and Rodrigo. So thank you, Tess, for making this link so that we could hear from you. So much appreciated there. So I don't know, Gordon, if you want to take the facilitation of the discussion or if you'd like me to do that, but I see your hand up. So why don't you go first?
Yeah, no, I just want to ask a question. I'd like to have you continue to the facilitation. Hugo, thank you for that. I might have missed it, but what hours during the day are you open?
No, totally, yeah, totally right. I didn't talk about it, but we are open since 10 until 7 weekly days, and at the weekends it's a little bit shorter, from 9 to 3.
Okay, let me ask a follow-up question. And then I think we'll have a lot of questions from the other members. I'm really curious about where people use when you're not open. And whether we track data that shows how your population does over a period of time, because they're not obviously always using at the site. And so, I visited your beautiful city a couple of years ago, so that your site would have been open. And I was quite impressed with what I saw. I wasn't there. I was there to vacation and enjoy what you have there. But I asked a lot of questions and was observing things. So I'm wondering what percentage of the people of your clients are homeless, if any?
Okay, so we can say that from 20 to 30% are homeless. And about the first part of the question, so this is that's why I focus on showing what kind of neighborhood we are in too, because this is a drug dealing neighborhood. So it's 24 hours of buying and selling and using drugs. So when we are closed, people use right next to our door.
In public view?
Yes, it's a public view. It's tolerated because it's a drug dealing neighborhood. It's almost we can say that people that comes to this neighborhood, it's only to buy, to use, or yes.
What about my last question, Carol? I promise. We have a lot of adolescents who are using under age 18. And so I'm curious as to, I mean, we see, I think, generally use, unfortunately, at an earlier and earlier age. So what services are there in Lisbon if you are approached by a 14 or 15-year-old? Do you have another place you can send them for help?
Well, it's a it's a difficult question, yeah.
Yes, but we don't have many people who come here and is under 18. Is very rare that happens. They don't come to this. This is a heavy neighborhood. It's a very heavy neighborhood, and most of the people who is in this place are heavy users for a long time. So it's very rare that we have people under 18 that come here to search our services. But if they come, we can. But we have it.
Yes.
It happens, but it's very rare, and there is no other place that we can refer these people because there is no other place of drug consumption room, other drug consumption room in Lisbon. So.
Great. Thank you so much, Hugo. Anyone else want to jump in after Gordon here? And Tess, I admit I'm looking to you because you've actually had the pleasure of visiting the site in Portugal, and I wonder if there's anything in particular you'd like to flag for us right out of the gate, your impressions or anything else about it that jumps for you as being helpful to the group.
Sure. Well, does anyone else want to go first with questions that they may have? And I'm happy to go after that.
Okay. Any others? Jen, thank you.
Hi, thank you for being here today. And there wasn't one reason why I want to go to Portugal. Now there's many more. So I appreciate your presentation. One of the things in Maine that we've had a lot of conversation around is community conversations and the importance of community education, awareness, recognition. And I know that you described this community that your center is in was already in a community where there was a lot of high use. But could you talk a little bit about what your experience was with the community? Did you engage in community conversations? What did that awareness raising look like? And what was the feedback from the community?
So thank you for your question. So we started, well, the project, like I told you, we had a lot of conversations with some partners and also with the local community, local partners and local community. And since then, we have been doing our work, trying to connect with the community. And how can we do that? So in our work, for example, we have a community team here in the drug consumption room that goes around the neighborhood every day during an hour to pick up some syringes, but also to try to contact clients that are using in the streets and invited them to come in the drug consumption room, and also to pass around the neighborhood, to go to around the coffee and everything. So to try to connect with the neighborhood. And also, so we are not open for a long time, but we have every month, I think, we have meetings with the local partners and local community where, for example, the police is in. So we talk about the problems of this specific place, and all the actors working and living here are represented in this meeting. So this is also a very important moment. And I think another big example is that we are linked to another institution in the neighborhood, and we are providing, for example, screening for elderly people. So one of our nurses is available to go once a week to do screening for those people. And also we have also a straight connection with a boxing association in this neighborhood, and there's a bakery that provides us a lot of bread from a donation every week, and we split with this boxing association because they have some families identified and they need this kind of help. So I think this is yes, this is how we try to engage with the community.
Thank you. That was really helpful.
Thanks so much, Jen. Other questions from the working group members? I wonder, Hugo, I just, while people are collecting their thoughts, I wonder too, if you could speak just a little bit to you described the fixed sites plus mobile sites. And could you just tell us a little bit about the mobile model?
So the mobile model that I showed you, it's a mobile methadone van, which is different from, but because there's a mobile drug consumption room here in Lisbon. It's very effective to go where we cannot have a fixed facility. It's not so effective because that's only two places to use injected. There's no place to use smoking, which in Lisbon it's still the most important way of using drugs. It's smoking because of the increase of crack cocaine and so yeah, but I don't know if you were asking about the mobile methadone or
no, you answered that question. Thank you.
Oh, okay.
I was thinking about the consumption sites. Thank you.
Okay.
Yeah.
That does bring me to another question, Hugo. You probably are generally familiar with other sites in your nation of Portugal outside of Lisbon. How many sites there are, and do you communicate with these other sites?
Communication in what way? So
well, like, would you have I don't have any idea. Like in Canada, there's 39 safe consumption sites, plus public health urgent need sites. So they could have 50 places across that vast area of land. So I'm kind of interested in, well, how many places in Portugal are there? And if there are quite a few, is there a little formal or informal network where this is all legal in your country? Do you get together and compare notes and best practices, etc.?
Yeah, no, not at all regarding the drug consumption room. So there's only one fixed in Lisbon, one fixed in Porto, which is and it's the second city in Portugal. One mobile in Lisbon. So these are the main consumption rooms. There's another one in Lisbon, it's official, but it's not funded as well yet. It's like a more community-based drug consumption room run by another NGO here in Lisbon. But we can say that we have one fixed in each big city and one mobile in Lisbon, another one. So we have no, it's not a network because we are not so many, but we have an harm reduction network in Portugal. So yeah, because we have lots of partners and institutions that provide outreach, other kind of work, shelters, and working in that kind of services.
Excellent. Thank you.
Thank you. Time check. We have about 9 more minutes with Hugo and Rodrigo. Anyone else have questions, comments?
Carol.
Jonathan?
Yeah, thank you both for being here. What kind of, have you seen a change in the different, or the types of drugs that are being used in the facility over the years? I'm just kind of curious if you've seen shifts from one to the other, or if it's always been a certain one and it's just kind of ebbs and flows.
No, fortunately, we are still dealing with heroin and crack cocaine, and both of them mixed. It's mostly around this. We have some cases of people using benzodiazepines. Well, but it's the main picture that we, yeah.
And when you
still.
say heroin, have you seen fentanyl, or is it mostly
No.
still heroin?
No, still heroin.
Okay, and how
Just
about methamphetamines?
No.
Okay, thank you.
Thank you, Jonathan. Anyone else? Tess, do you want to jump in here? Oh, Rick, I see you.
Yeah, just real, and again, Hugo, and I appreciate you both coming and doing the presentation. From a law enforcement perspective, I just curious about any concerns that you might have with, some of your clients or patients coming in that maybe have violent tendencies or concerned about safety of your staff. And can you share a little bit about? I didn't notice any issue, any of your staffing having to do with security, or just curious to see if you've had any issues in that line.
Yeah, good question. So we have no security in our staff. We have, fortunately, a very good relationship with the police. We work together since the beginning, since after before opening. This is a drug consumption room, so sometimes we have problems inside. I can say that probably we had 3 or 4 serious situations with involving aggression between the client and the team. And in this, when it happens, we call the police, and usually they come very quickly because they understand that when we call, it's because it's important to come. Well, but yes, it's always risky. It's a drug consumption room. There's drugs. There are people with psychiatric condition using crack cocaine. So it's a drug dealing scene. So it has some risks, but fortunately, we also try to train the team to be very humble, to be very empathic with people. That's why this is not only a drug consumption room, this is an integrated services. We are very focused on the patient and the client's needs. So we provide the most basic support. So I can say that, yes, the big majority of the time, this is a very quiet and peaceful place.
Thank you so much, Hugo. Tess, what do you?
Just to say that in our NGO, since the beginning, we try that the relationship with the user is the main focus in our intervention. We try to establish the very good relationships and very close relationships with these people. and that until now, during all these years, I think it is a good way of dealing with the problems. Because one of my, for instance, we have here severe mental health patients, users, and one of my role also is to speak with the team how to deal with them, how, because most of them, they don't made any medication, they are completely out, and is trying to deal with these people and with these problems. And we have we think that if we had someone who was the security, the role of security, it is not good, because they don't like this kind of and we try to with the relationships and to try to be with them in another way, and in a way more empathic.
Really helpful. Thank you, Rodrigo. Tess, back to you.
Thanks. Yeah, I wanted to just give other people a chance, because I did have the opportunity to visit the DCR in Portugal, and I was blown away. It was a very meaningful experience, getting to know the staff and hearing their compassion and care for people that are clearly struggling. I know in the United States, we often have this tension between addiction is a brain disorder that needs public health approaches, or the drug user is a bad person that's making this active choice, and maybe punitive measures like incarceration would be the right fit for them. And I was very struck in Portugal, especially that, you are a country that has decriminalized the possession of illicit substances, that in almost every professional that I talked to, there was this clear acknowledgement and understanding that folks that are struggling with addiction will have better outcomes when they're treated like care and they have access to DCRs. I was wondering if you could just talk about, what happened in Portugal that led to such a shift where public health approaches became the norm. And can you talk a little bit about public acceptance of that shift? And if whether or not that's evolved, is there any pushback to DCRs? I know we only have a couple minutes and that's a loaded question, but I think it could be really helpful for this group.
There is an history behind this, the decriminalization, yes. Because in the 80s, in the 90s, we had an heroin epidemics here in Portugal. We had 100,000 people with problematic use, mainly heroin, and that problem touched all the levels of the society. It was the number one concern of the population was drug at the time. It was a very difficult period, and because this became the number one concern of the population, politics, they decided to do something. And now fortunately we had success in this in this approach. But what happens now is that the drug is not a big problem in Portugal, and so the politics are disinvesting, disinvesting. I think that we can say it in this field. So But at the time, it was a big, it was not only decriminalization by themselves, itself, doesn't resolve the problem. What happened in this in the 90 end of and in the 2000 when the law was was done. It was a big investment in harm reduction services, big in treatment services, etc. At the same time of decriminalization, it was a big investment by the government in put in the field answers and to this problem. So that's why decriminalization was accepted by the society, because almost all people had some in the family who consume drugs. So it was, and then they don't. Even politics, they had also family that consume drugs, etc., etc. So they prefer that these people, that the family doesn't go to the jail, and that it was better to see this kind of problem as a health problem, and it is a health problem, as it was also one of here we people who began to work with users. We always saw this problem as a health problem, and so it was possible in that time to do this decriminalization. That population agree, all the population agree with that. And we have no, even now, there is no big problems. All the parties, not the extreme right, but all the major of the parties that here in Portugal, this is not a question. Decriminalization is one thing that is established and is not a question for the parties now. So
Thank you so much. Oh, I apologize. Thank you. Yes, that was really helpful. I just am so grateful again, Hugo and Rodrigo, for you being here today. And we just can't thank you enough and appreciate your time, and especially late in the day for you. So thank you again, and we will let you go and get on with your evenings.
Thank you for the invitation, and we are still available if you have any doubt or anything.
Yes,
Feel
it's
free.
a pleasure.
Yeah.
if you need.
Yeah. No problem.
We appreciate
All
it.
right, terrific.
Bye-bye.
Well, thank you again.
Yeah, and congratulations for your work also, and I hope that it's going to help on your objectives.
Well,
Thank
thank you.
you.
Good. All right, take care.
All right.
Bye-bye.
Bye-bye. Thank you.
Thank you, working group members, and that was a terrific discussion. And so wrapping that up, we were joined by Dr. Elaine Heischke, who's here from Edmonton. And so we're going to make a very swift pivot to Elaine. Elaine, I'm Carol, and I know we exchanged emails. We are so honored to have you here, and so thank you very much. I won't ask the members to introduce themselves, but when we get to the Q&A, if folks could just say their name and their organization, that will help Elaine get oriented to where you're coming from. Elaine, would you like to screen share? You should have the ability if you'd like to, or you can just talk with us.
I have some materials that I did prepare as background, which I'll happily share with the committee after. And if I need to share them now, I'll share. But for now, I was thinking we could just have a conversation and I can give you some background about where I'm coming from.
Great.
So,
I wanted to give you a little bit more introduction, Elaine. I'm Gordon Smith from the governor's office, and I chair the working group. And I spent a lot of time a couple of weeks ago with your document, your 135-page national operational guidance. and became aware that you chaired the group that did that, and of course learned at that time that you're an associate professor and Canada Research Chair in Health Systems Innovation at the School of Public Health in the University of Alberta. So I think it's important for our group to know that you are an academic person. You have a wide experience in the whole nation of your research. So unlike most of the presentations we've had are really from operators of the sites, including a site in Cape Breton that we heard from
Oh,
just
excellent.
a week ago, the one in Sydney, and we've been also in touch with people in Quebec and in Ottawa. But we are so lucky that on short notice to have you offer your perspective as a researcher and having had long experience with these sites. So just thank you so much.
Oh, no problem. I'm happy to join you. And to be, just so you know, back in 2017, I guess, 2016 and 2017, 2018, I was co-chair of our Provincial Opioid Emergency Response Commission. And through that process, we allocated $60 million to support new initiatives to fund to prevent overdose deaths. And part of that included implementing supervised consumption sites in Alberta, or sorry, overdose prevention centers. Is that what you guys are calling them? The American term. But yeah, and I also was very active in the implementation of 4 here in Edmonton, where I'm from. I collected the needs assessment data that informed the development of the service models. And then for the first 3 years the sites were operating, I was responsible for aggregating all of their operational data and compiling the reports and submitting them to the province as well as Health Canada as part of their funding and exemption requirements.
Amazing. Thank you again. We'll turn it to you. Thank you, Gordon.
Sure. So I guess I'm so glad to hear that you met with colleagues in Sydney, because I actually have a graduate student in my research lab, and we were talking about your commission, and she suggested them as like probably the most akin to your setting, like in Maine. I haven't had the fortune of visiting Maine yet, but in 2018, I was invited by the US State Department to travel to the United States as one of 5 Canadian experts to learn about the opioid crisis response. And I made it as far as Concord, New Hampshire. So I'm a little bit familiar with the circumstances that you're facing. And I guess, yeah, like I have a broad breadth in supervised consumption services. I'm very, very familiar with the models in Canada. I'm currently conducting research that includes aggregating some of their process monitoring or like outputs data across the country, as well as doing qualitative interviews with operators. And I would note that we also have recently compiled a list of the rural and remote setting SCS or OPCs. And so in Canada, there's this community with the smallest community that has a OPC is 100 Mile House in BC, and that's 1,980 people, so quite small. But most of the centers would be in sites that have anywhere between, I'd say 20 and 20,000 plus in terms of population. I've seen successful models implemented in rural or more remote settings. I've also seen less successful models. And I remember when I was co-chairing our Provincial Opioid Emergency Response Commission, there was a spike of drug poisoning deaths on the Blood Tribe Reserve in southern Alberta, and the province sent a trailer. We call them here ACO trailers, but they're essentially like, kind of semi-permanent trailers that are on wheels that can be moved around, but sort of like, I guess, almost like a mobile home, but not a home. It's a trailer. And so they sent that to the Blood Tribe, and actually nobody accessed it. And that was a learning, because we found out quite quickly that people, despite facing a significant increase in deaths in the community, a pretty small community, people did not feel comfortable going to that service or identifying as someone that would be using substances. You know, it was placed right beside the health center in town, and it didn't work. You know, I think the operators also were the provincial health authority and not like local community members, which I think made a difference. But yeah, that was one example. That being said, in general, I've seen these facilities succeed across the country in Canada, as well as particularly in my home province of Alberta, which tends to be, we have two large cities. Where I'm from in Edmonton is 1.1 million people. But outside of the major centers, the sites have been implemented in places with around 35 to 100,000 people. There's different models in Canada. We have services that are standalone, so basically purpose-built in a new building. We have services that are integrated into existing facilities. That's the model we've adopted in Edmonton. So already where people who use drugs were going, we just kind of added supervised consumption. And there's also mobile services where they attend a site for a specific amount of time on a specific schedule in a given year. Those are less common in Canada. We have also here a few mobile sites that don't move, but they were more acceptable in the communities where they were implemented because of the sense of impermanence. You know, that they're essentially trailers that can be easily changed. And then we also have some newer models of supervised consumption services that have emerged. We have our National Overdose Response Service, which is a telephone-based peer-to-peer overdose prevention. I know you have something similar in the United States. I'm not sure what the uptake is in Maine, but that I think is certainly promising for places that have more dispersed populations, or people that also like not everybody wants to attend a service that is identified as for someone who uses drugs. And so this allows people to enhance their safety if they have to use alone in their own home for whatever reason. We also have in Toronto a newer model called spotting. And so this is where community health centers have peer workers who essentially use their own home as a safe place for people to go to access sterile supply distribution, and sometimes also use substances. And it's a bit of a gray area legally here because they're not formally exempted places. So it can be a bit tricky to implement through kind of more formal established like health authorities or health services, but it is a valuable model in areas where if there's like, for example, in a large building in Toronto, if there's already a lot of people that are using substances in that building, engaging someone as a peer support worker and making their apartment a safe place where people can go to access the lock zone, access sterile supplies, and also potentially be observed during use or immediately, or, you know, or following use, or even just, you know, to let that person know you're using and have them check on you in a few minutes. Like those kinds of models have emerged here. And then we also have apps, like phone apps that essentially you open on your phone, you set a timer. If you are non-responsive when the timer goes off, EMS is activated. And those have been done in major centers, but also in more rural communities using, in Alberta, we have what's called STARS, which is like the helicopters and that support, you know, transport and also attend emergency scenes outside of major cities where ambulance coverage is more spotty. So it's the STARS ambulance that is supporting those. I'm trying to think if there's anything else I missed. Oh, and then of course there's also virtual spotting. So similar to telephone, can be formal, maybe informal, but it's typically someone who uses drugs is volunteering to, or not necessarily a drug user, but often a drug user is volunteering to connect with people online, monitor them on video, and then activate EMS if they become non-responsive.
Where do those, well, I can't speak for the whole work group, but I'm very interested in that model, Elaine, and we do have Safe Spot coming to Maine. Safe Spot's at the Boston Medical Center, a fellow by the name of Stephen Murray. And Stephen, I first met when he presented with someone from Canada, from your Overdose review the ORS telephone line.
From
And
Norris.
probably, yeah. So could you identify where is that all just happening in Toronto?
So we have NORS, which is a national telephone-based service, and it's very similar to the national telephone service in the United States, which I think Stephen Marie started. And it's essentially volunteers on one line. You call into the hotline, they talk to you, they let you know what they're using, they give you your address, and you set up a protocol for when you're going to call ambulance if it's required, and then activate an EMS response if someone becomes unresponsive. We have a lot of, really important to recognize that in Canada and internationally, most of these models first started with drug users taking care of themselves and really being peer-led, informal initiatives. And so when I talk about virtual spotting, that really is something that happened as an innovation during the pandemic that was led by drug user groups here. So people who use drugs are getting together either formally within their organizations or informally through their peer networks and just taking care of one another. And, the best public health efforts to address drug poisoning start typically as things that people who use drugs have come up with. And then we take them and try to systematize them and scale them up if we can. And so, when I talk about the virtual spotting and kind of peer-to-peer, that is really more informal. And so ways that could be supported more formally is, I think, to help people kind of work through that process, like what that could look like, what does EMS look like, making sure that there's legal protections for people if EMS are activated. Obviously the United States is a bit of a different criminal law context than we do around drugs. Not that different though, to be honest, but so just making sure that there is as many protections in place as possible to facilitate these kinds of behaviors that prevent or promote safety.
Thanks.
Elaine, I wonder if you had more you wanted to share as a setup, or if you want to open it up to discussion at this point.
I think I'm happy to take questions. Yeah, like I'm not sure what you've heard from her, like what you've already heard and what you're quite like where you're looking for more knowledge. So if you want to ask questions, I'd be happy to provide answers. And if I can't answer them, I bet you I can send you something as follow-up that will answer it.
Okay.
Let me start again, Carol, before moving on to others on the panel. I don't know whether you know that following our talk with you today, Elaine, we're going to be hearing from the site in Grand Prairie, Alberta.
Oh, Northreach, yeah.
Northreach. So we thought it was pretty rural. It's probably bigger than we think as a city. But I want to make sure you knew that. Secondly, you didn't talk, one of the models is this urgent public health needs designation, and their exemption under Health Canada is different than the other 38 or 39 sites. I'm not sure how many there are. I think actually the site we talked to in Sydney is an urgent public health needs site. Can you tell us anything about that distinction?
Yeah, it's a good question. I think it's primarily a distinction without a difference. And that class of exemptions was really created as a way to kind of more quickly expedite exemption applications in response to emergent circumstances. So the urgent public health need sites tend to be implemented in smaller communities where drug poisoning has started to increase and people are getting together and asking directly to Health Canada for support, often without funding, like formal funding from the government. So in Canada, the federal government does not fund these services. Any funding that is provided to services almost always comes from the provincial government or the territorial government. And in some cases, it is actually like nonprofits that are raising money to support the operation of the services. But most are provincially funded. So the urgent public health needs sites would be more likely to be funded by alternative sources of funding than provincial money. So like less certain operational dollars, and also implemented in places where maybe they're not sure if it's gonna for sure work. You know, like they're not sure if they have the critical mass, or they're not sure that what the hours should be. And so it's more of like a temporary measure that they're going to try it out. But in general, I think the model is the same. Like they're supervising consumption. They may have fewer ancillary services like access to opioid agonist treatment, or access to like wound care and things like that. But the model is similar. It's kind of similar to what in a BC they call overdose prevention sites, which when that province declared a provincial health emergency back in when was it, 2018, I think, they just stood up a whole bunch of like almost very temporary services that eventually became more institutionalized, but in some cases started as just pop-up tents outside that were just a place for people to go and use and receive emergency medical aid if needed.
That's great. Thank you.
My last question is that there have been sites in Canada which have closed.
Mhm.
And I'm interested in the extent to which you know whether there's any commonality to those that have failed, closed, lost funding. Is there something for us to learn from there? Did they tend to be urban, rural? Maybe there haven't been that many, but there's some.
It's almost always politics and community backlash against harm reduction. Yeah, in some cases, it's, you know, if a site has opened and they didn't have operational funding, they're going to be more likely to close, because operating the services, you know, does take resources, right? Like you have to fund the staff have to have a certain level of training, things like that. But generally speaking, when we talk about SCS closures in Canada right now, it is because we are nationally experiencing a serious backlash against harm reduction approaches across the country. And where I'm from, it's the epicenter of the backlash. And so the sites are constantly under pressure because they're being used as political wedges in debates over how, like, basically they're being used to they're being used by populist politicians to basically set up an enemy of people who use drugs to other them, and to stoke fears in communities. And the SCSs are being scapegoated for much broader structural issues that are not getting enough attention in our country. So for example, where I'm from, I'm in Edmonton. Our homeless population has quadrupled since 2019. So we now have like close to 5,000 people living unhoused in central Edmonton, where my office is. At the same time, drug poisoning deaths are finally declining, like similar to what you're seeing in the United States. But you know, they remain elevated compared to pre-pandemic levels. And so basically political actors have capitalized on these two phenomenon and said, this is a sign that supervised consumption sites have wrecked the neighborhoods and we need to close them down. And that's an excuse they're using to not address the fact that more people are living in poverty and more people are unhoused, and people are using drugs on the street because they're unhoused. And there's just more people, you know, in Canada, it's about 60% of people who are unhoused that also have problems with substance use. And so there's a lot of overlap between the populations. One thing I think is really important, I always think about the lessons I've learned in doing this work. And this has been, you know, we started this in 2012 here, and we got the sites going in Edmonton in 2018. And it's been a ride ever since then. First of all, in Alberta, the sites have reversed over 1 million drug poisoning events. So I'm very proud of that. And I think that has saved countless lives here. But what I wish we had done differently, had I known or been able to see into the future, is I would have ensured that the sites accommodated smoking. We could not predict in 2012, and even in 2017, we didn't really know that the patterns of drug use were going to shift so dramatically towards inhalation. I can't understate how dramatic the shift has been from injecting to inhalation in our site. So people who use opioids here now are primarily smoking them, as well as we have always had a lot of psychostimulant use here, like methamphetamine is very big in Alberta. And so we have a phenomenon now where people are smoking drugs outside the supervised consumption sites because they're not allowed to use them inside. And that is causing problems because obviously there's visible drug use outside the sites. Nobody wants that. And it's also really stressful for staff because they're often having to respond to drug poisonings that are, in minus 20 degrees Celsius here in the middle of winter. People are at risk of frostbite in a few minutes, and they're responding to drug poisonings in very suboptimal conditions. So that is, I'm assuming you probably have similar patterns in terms of a lot of people are smoking now in Maine, and I think it is a little bit more tricky to implement inhalation because of like safer, smoking bylaws and things like that. Like in Canada, we have very strict regulations around occupational health exposure to smoke and also restricting smoking in general. But it is possible to get around them, and smoking safe, like inhalation facilities do exist in Canada. I could probably even dig up schematics for one that was operating in Lethbridge before it was closed. And if you can do that, it's very, I think you really should. Like that's like my biggest regret about the whole thing is not having accommodating inhalation.
Well, I can offer 2 points there, Elena. We just got done with Hugo Ferrier in Portugal, and their site has increased the slots for inhalation. But in Providence, Rhode Island, which is really the third site in this country that's now open, they have.
Oh, it opened? I didn't know that. That's great.
They've been open. They had kind of a soft opening a couple weeks ago. I'm going to be down there Wednesday, at least in Rhode Island. And I've been through the site, but there was a lot of attention to the 2 smoking rooms. So they've got quite a large capacity, because I think people now realize that. I mean, I'm not the expert here amongst all people with us, but I mean, I think we have seen some movement from injecting to inhaling. And in many cases, for the individual, that may be a good thing. But I guess my question to you is, why haven't the sites then simply renovated and made room for a couple of smoking rooms?
That's a good question for a number of reasons. So first, our real window of SCS expansion in Canada ended, I'd say, in kind of 2022. And that's really where we started to see a lot more backlash. So really like the policy window has closed for significant new investment in these services in most places, not all places, but in most currently. I'm optimistic that it will eventually open again, but this is the way drug policy works. It's very much 2 steps forward, 1 step back, and it's very iterative. So that's one. So for example, in Alberta, every operator here has wanted to do that and has asked the provincial government for permission to do that and has asked for funding to do that. And they're just getting no's across the board. A second issue is some places don't have the space to accommodate inhalation or the retrofits required. And it is very hard to move to new buildings, as you can imagine, because you have to get, a new license. Often community, like neighboring businesses might oppose that. You have to find a landlord that will rent you. Like it's not that easy to port these services around. So those would probably be the 2 things. And then to a lesser extent, the regulations around smoking. Like some sites, I think, just feel like navigating that process, especially the lower resource sites, would be too much. That being said, you can supervise inhalation in an outdoor environment quite easily. And there's a hospital in BC that has people posted on their rooftop patio because patients keep overdosing on the campus. And there's nurses that watch the patio and support people in just a tent, like a pop-up tent with plastic, like vinyl walls, and just make sure that everyone's staying safe if they have to use while they're hospitalized. So it doesn't have to be expensive to accommodate inhalation, but if you can find a place that has like a concealed courtyard or something like that, I think it is often probably the best bet for doing that most efficiently. Yeah, otherwise you have to have a lot of like ventilation and potentially even like negative pressure. And it's going to depend a lot too on the state laws around occupational health and safety and what your inspectors are saying.
Jen.
Thank you for that. We had some folks from Vermont join us, and they are grappling or were grappling with this at the time as well. So that's a really good angle to cover. Jen, I see your hand up.
Sure. Thank you. Thank you so much. This is a continued helpful information. So as you know, this group was brought together to put together a report to provide recommendations to the legislature. And building off of your sort of lessons learned, if you were in our place, what would you make sure would go into that report?
Good question. I think it's really important to set your expectations realistically. So I definitely walk the line between researcher, but I'm very applied in my work, and I'm a public health person. And in public health, the core competency is advocacy. So, I'm always out there also talking about these sites in the media and things like that. So it is very sometimes tempting to say these sites will save lives, these sites will bring down HIV rates and all these things, and they will contribute to those objectives. But it's very rare that you could demonstrate a population level impact of the sites within the first few years of operation. And you have to be really careful, because sometimes that will then be used against you. And it's not that you aren't actually contributing to a number of positive health outcomes. It's just that the reality is, even a high volume site is only going to supervise a fraction of the number of drug use episodes in the community, right? Like, because people use at night when it's closed, or even if it's 24/7, they don't always make the trip to the site. People will still use when they need to use, and that's just the reality. And so because of that, achieving population level impact can be hard, especially in smaller centers, where people are more spread out and there's a smaller number of people. We have demonstrated it. And, I'm sure you talked to Brandon Marshall, or maybe you will, from Providence. Like, his research in Vancouver before he moved to the US showed within the neighboring blocks around Insight, the mortality rate went down. My colleague Dan Werb in Toronto showed similar things when they opened sites. Like, in the immediate blocks surrounding the facilities, mortality has gone down. Whether you can show that in a place like Maine, we're going to have smaller numbers of people that are accessing the service and people are more spread out, it's not guaranteed by any stretch. So I would just be careful about setting expectations. I also think it's really important to distinguish the point and goals of these services. I love opioid agonist treatment, and I would love for every single person to find the right form of medication that could work for them and would get them, if they want, to stop using drugs. That being said, opioid agonist treatment is one tool. OPCs are another tool, and they're distinct. They're not interchangeable. And often what you hear in Canada now is like, well, we've tried the supervised consumption sites, they don't work. Let's just focus on treatment. They're complementary approaches, and they're best implemented together. So I would just be very clear. Supervised consumption services serve the portion of people who are often the majority that are not seeking treatment. They're, in a given year, we know from psychiatric epi studies and from lots of research, especially in the US, you guys have much better data than us on this. The majority of people that have a substance use disorder do not seek treatment in a given year. Supervised consumption services are targeted at those people, and that needs to be really clearly described. And they serve people that don't just use opioids, right? They also serve people that use stimulants. So they're serving a broader target population, and they do connect people to treatment if that's what they want, but that's not their fundamental objective. Their fundamental objective is providing emergency medical aid when somebody is at risk of dying. And so in that way, they serve almost like an emergency department, in that they, provide that emergency aid, and then they triage people and connect them to other services. So I just think it's really important to set that up as an expectation, because, people that oppose harm reduction, and there are always people that oppose harm reduction, this is a philosophical, difference. And it's an area of what we call in academics like morality policy, because it involves fundamental conflict over values. There's always going to be people that oppose harm reduction. Those people will often try to say, well, deaths are still going up, or deaths didn't decline as much as we thought, so we need to close this service. And so just setting those expectations accurately, I think, is really important. I think also I think it's really important to have people use drugs involved in the services. And I would really think that should be reflected in the report. The services will build trust faster, engage more people, and engage them more effectively if they're run by, or at least staffed by, people who use drugs themselves. It's just a universal observation we see across harm reduction. And I'm a public health person, and I love public health, but public health sometimes is not good at implementing harm reduction in an effective way. So I think really recognizing that you need to support people who use drugs to be able to work in the sites is really important. And, you know, and that should be, yeah, like that should be reflected for sure. What else? The inhalation issue for sure. And then ongoing monitoring. And if you have the opportunity, start collecting the data before you implement. I think that cannot be overstated. You know, again, like people like to use like the sites become scapegoats and you just have to be careful. So if you can, like, for example, in Saskatoon, which is our neighboring province of Saskatchewan, it's a smaller community. I think it's 300,000 maybe, or less than that even. They opened a site with their own money because the government is very conservative and would not support it. They started collecting data and taking pictures of the building that they were moving into 6 months before they moved into it, just to show like, hey, there's already people using drugs in this area. There's already garbage on the street in this area. Like there's already discarded supplies in this area, just to be able to show like, we are not, you know, we didn't cause this. And then when they opened, they actually used some of their funding, to their credit, to hire staff to go around and clean up every morning before businesses opened. So like they were providing a community service that, you know, in my view, they were not responsible to be providing that, but they did that in part to continue to build goodwill with their neighbors and to do their best to lessen any perception that they've had an impact on the neighborhood in a negative way. Other sites I've seen have hired like outreach workers or even security that help to support businesses that may be engaging with people who are using substances and, you know, sort of like a crisis diversion type response. That sometimes helped. It just depends, but it's tricky because the sites tend to be implemented in areas where these issues are occurring. And so when they're implemented there, then they sometimes become, you know, seen as the cause, but it's like typically that like the kind of open drug use and things like that are what attracted the sites to the area to be opened in the first place. And that's kind of why I always recommend, if possible, implementing in existing services, because the people are already using there. There's already probably unhoused people in that area. So I think the perception that things have changed substantially is lessened when you're implementing into existing services. And you know, in Edmonton, the police were really skeptical here of our sites. They actually they had their own officers parked outside the sites taking pictures pre-post because they thought it was going to be like this big gotcha where they were going to have all these pictures to show that, you know, there's people using drugs everywhere here now and there's supplies all over the place. And they presented this report to city council and I was at the meeting and the neighborhood got improved, like the conditions improved. And so it wasn't quite the gotcha that they thought. And in the end, the police ended up supporting the sites. And they also monitored crime around the sites and they saw that here, crime didn't increase, and in some instances, it decreased around the services.
That's interesting. The community goodwill is almost a theme of what we just heard from Portugal as well. And so that's interesting that you've brought that up as well. So thank you. That your feedback was really, really informative.
Yeah, and one other thing I'll just note is in Edmonton, when we first started, the federal law kind of required the municipality to be involved with a letter of support. And so the municipality took on the role actually of convening a neighborhood group of businesses, residents, and other stakeholders, along with the supervised consumption site operators. And we met quarterly. I used to be the researcher on the meeting to talk about if there was pressures on the residents or the businesses, or if the businesses had questions or anything like that. It was just an open forum that was moderated by the public health officer and someone from the city that just kind of facilitated open discussion. And I also think that that helped in the early years to kind of diffuse any potential issues. That's not to say we didn't have issues, and there was certainly still opposition, but I think that was a really valuable forum for bringing like business associations and things like that on board.
Back to you, Carol. You're on mute.
Yeah, thanks, Gordon. I was just going to express our tremendous gratitude for all of that. That right there, that last question that you asked, Jen, was amazing, Elaine, that you could lay that all out for us so clearly and succinctly. I don't know. We have our next guest. Dallas is here from Grand Prairie, which is really exciting. But I also know that maybe folks didn't are there other questions, or should we create, Elaine, if you were amenable, maybe we could send you an email with anything follow on? Okay, and you said you
Yeah.
would send us some materials to read?
Yes, two of my students who've been working on a little project doing an environmental scan of smaller STS OPS have prepared some preliminary results. I can send those to you. They're not like, peer reviewed, but like, and they'll probably evolve a bit, but it's a preliminary draft that might be helpful. I also have a spreadsheet they compiled that just tells you the size and location of all the smaller, like the more rural and remote SDSs in Canada, if you're curious. We have about 90 facilities total here.
Not 90,
Mm-hmm.
so that you're including the urgent public health sites and
Mm-hmm. Yeah, I can't know all of them because some of them are really below the radar and only Health Canada knows that they've been approved. But yeah, I did have a student like deliberately Googling like all of them all summer and checking, Health Canada registries and things like that. And like any kind of online mention of the sites. So I think we have a pretty comprehensive list.
well, your report even acknowledges an additional category of like overdose prevention sites that are not that did not receive an exemption. That I
Yeah.
kind of read it and said, well, they're kind of things that's flying under the radar screen and are effective in the community, but they're really not part of the official system.
Well, yeah, in BC, they were supported by the provincial government, but at the time, the provincial government didn't have the authority to support them with exemptions. And so it's sort of similar to like, I think the New York sites where like federal law technically is not supportive of overdose prevention sites, but the state has moved forward. That would be like kind of a similar thing.
Well, in that case, actually, it was the city of New York that made those sites possible, working with the police department. In Rhode Island, the state passed legislation authorizing it, but still it's the city of Providence that's been the welcoming environment. And that's what's anticipated in Burlington, Vermont later this
Mhm.
summer. So it's clearly we are a work in progress. But how far is it, by the way, from, do you know, Dallas up in Grand Prairie? I guess it's a big province, so you're not actually that close together.
I think I've been on meetings with Dallas, but yeah, it's like what is it, like 4 or 5 hours drive?
4.5.
4.5, yeah.
It's probably not a
Yeah,
lot.
and I know I don't know if Johnny's still at Northreach, but I know Johnny no, okay, pretty well. So yeah, I haven't actually had a chance to visit Northreach though, but I have been to Grand Prairie before. But yeah, so we're a little bit removed. But anyways, I'll turn it over to Dallas. I know they have amazing experiences and expertise from Grand Prairie, but if you have any further follow-up questions or even like honestly, I'm happy to answer anything. Like I try to stay really on top of what's happening with SCS and OPS in Canada. And so if you had a question about Canada, I probably know who to connect you to, or I know the answer.
That's amazing.
So it's been
Elaine, thank you so much.
terrific. Terrific,
Thanks, good
Elaine.
luck, and thank you for your efforts.
Amazing. Well, again, I'm going to make a quick pivot to our next guest. Dallas Sather's here from Grand Prairie, Alberta. I had the chance to chat with Dallas yesterday afternoon and just kind of get situated a little bit in what we were hoping to hear about. And I'm just really looking forward to this conversation. So Dallas, thank you again for joining us and again saying yes to this invitation at relatively short notice. We really appreciate it. We aren't going to go around and introduce ourselves to you just to save time, but if someone does have a question, if you all can just say your name and anything about you organizationally, that would just give Dallas some perspective. That would be tremendous. So, Gordon, I'll turn it to you to welcome Dallas.
Well, Dallas, I know you're a nurse, as I understand it, by background, and executive director of Northreach Society. I'm Gordon Smith. I'm a lawyer who works in the governor's office and have the privilege of being the director of opioid response. We just had our 6th anniversary yesterday, actually, and of our work. And as I say, I'm a lawyer, and our working group is a wide variety. We're missing the 2 physicians today, actually. They both are elsewhere, but we've got public safety, clinical people, harm reduction people, and we are so appreciative of you taking time to share with us what your experience up in Grand Prairie. And I'd like to have you just take a minute or two to tell us a little bit about yourself, but also tell us a little bit about Grand Prairie, because I suspect that most of us haven't been there.
Yeah, I suspect you have not been here either. So we are north of Edmonton, about, like I said, northwest, about 4.5 hours, 420 some kilometers. We are just slightly north of the 55th North, so we're quite north as far as latitude goes and longitude. We are a chilly city in the winter and a beautiful city in the summer. And fortunately, when it's really cold, it tends to still be really bright and sunny here. So we're thankful for that. We are a relatively small city by city standards, but because of how remote we are, we tend to deliver almost all services that you could imagine. So we have a regional hospital, robust primary care networks, and service a very, very large area called the North Zone in Alberta, which is kind of our medical zone. Myself, yes, I'm a registered nurse. I've been a registered nurse since 2002. I graduated from the University of Alberta Bachelor of Sciences in Nursing program. To bring it a little bit more recent, 6 years ago, Northreach opened a supervised consumption site. And that's how I ended up at Northreach. I was hired on as the inaugural team to open the SCS and get it going and actually work on it, responding to overdoses. I stayed in that role for about a year, then moved into some education roles around naloxone, community education, that sort of stuff. Then COVID hit, and so then we had to get very nimble, and we opened up a COVID hotel for people who were experiencing homelessness that had a positive COVID diagnosis. What ended up happening is we designed a mobile opiate agonist therapy program in order to help all these folks who ended up in forced withdrawal from being forced into motels. So what we found through that program was just a real ability to, that when push comes to shove, we could get nimble and serve folks' needs and help them kind of in that recovery piece, and prevent their death from an accidental overdose from like unreliable drugs, I guess, being delivered to the motels. After that, our ED went on leave, and then he didn't come back, and here I am. So I've been kind of through like the entire agency with we have a real focus on serving people who experience opiate addiction, other kinds of addiction, homelessness, at-risk folks, that kind of thing.
Tell us a little bit, what's the population of the greater Grand Prairie area?
Oh, like the population we're serving
No,
just
the general population.
just the city. Carol, you probably have more recent stats than me. You said you just looked it up yesterday. I think we're sitting around 70. Does that sound right?
Oh, wow, that's interesting, Dallas, because I looked it up and it said 35, but so that must have been just
no.
the central inner city.
Okay.
Yeah, okay.
Yeah.
So the greater Grand Prairie is
So, I mean,
around 70. Okay.
Yeah.
I mean, it's roughly the size of our largest city, Portland.
Right.
And but I tend to think that the areas around you are even more rural
Yep.
than some of Maine. So you serve a large rural population, probably some indigenous
Lots.
populations too.
For sure, lots of Indigenous communities in the area. So the city itself has almost 70,000 people as of 2024. That doesn't include the county or greater Grand Prairie.
You have
So
numbers about the number of clients you're serving every year, every week, whatever.
yeah, it kind of depends. Our homeless, like our people experiencing homelessness, I think is sitting around just under 300 right now. It's quite high because it is a hub for the North. I'm sure to a certain extent you all experience that too, right? Where you have these smaller towns and there's no resources for folks struggling, so they end up here. And then what they find is there's not a lot of resources here. So then they end up homeless here.
Yeah. Dallas, I was intrigued by the model
Yep.
and that you call it a mobile model, but it doesn't move. And we just heard Elaine say that some of the mobile models don't move, and here you are, you have one. I wonder if you could just give us an overview of the model, the authorization that you have, and really just how it works in terms of both how the services are integrated and how, what your outcomes are as a result. And also you told me some interesting things about the way you work in the community. So I think folks would be interested in that as well.
Sure, no problem. So yeah, it is a mobile supervised consumption site, and you can look at our website to see it. So it is actually a vehicle on wheels, and it does move every day in the sense that we take it to the spot where it's going to hang out all day and then take it back to the shop at night. It's a little bit of a workaround, for lack of a better word, because the people of Grand Prairie did not want to see any kind of permanent site. And having something that looked more mobile implied that this was going to be a solution that we wouldn't need forever. Due to the exponential growth of homelessness, mental health, and addictions in our province, like, this isn't going away. But it is a bit of a workaround in the fact that we didn't have a facility, like a permanent facility. So optically it helps. And the rule with kind of mobile vehicles within cities within Alberta is I think they have to move every 3 days. But ours moves every day. So just kind of to give you that. And so for us so where we do is we keep it actually behind the shelter during the day, because that's where the majority of the folks that access the SCS live and spend their days. For us to move that vehicle to a different site, say to the park where a lot of kind of our urban campers and people that live rough are, would mean we would need to notify the federal government, and we need an actual different exemption in order to operate it at a different spot. So what that means is that the exemption exists for where we are parking it right now. We could get another exemption to go elsewhere, but there isn't really a lot of point in our city. The reason we don't move around to other rural communities with this, and I think that ties into kind of what Gordon was asking about, like our rural area, there's a couple of reasons. The smaller the community, the more private drug use gets, meaning that like the odds of access of a consumption site would be very, very low because the shame and stigma around opiate usage. So folks that are housed, in our opinion, are very unlikely to use supervised consumption sites. In our area. I can't speak for other areas, but certainly the way it works here. The other thing is it takes a great deal of time for the nurses and paramedics to develop relationships for the clients, for them to feel comfortable consuming substances kind of in front of them. So it's quite a long period of kind of trust development and relationship development that could not happen if the vehicle was moving everywhere. So that's kind of, I hope that helps. Is there any questions about that? Okay, and so then to move on kind of to our service delivery, we call it wraparound services, meaning that everything that Northreach delivers has a crossover somehow in programming. So for example, our supervised consumption site also has some funding to pay for some RNs to do opiate agonist therapy. So even though we can't have any of those OAT medications on the unit due to Health Canada rules that there can be that we can't keep any kind of drugs on the unit except naloxone, the team works as an outreach team, going and finding the folks that have been signed up for Suboxone, methadone, Sublocade, those kinds of things, and making sure they dose every day. And then with that, we do what's called like a virtual appointment through the virtual opioid dependency program here in Alberta. So we actually can help facilitate the client seeing the doctor when it works for the client, wherever the client is. So it might be outside on the street, it might be inside the shelter, it could be like many, many places. But that way the clients are less likely to miss their appointments so that they don't fall off program. So that's been fairly groundbreaking. There's some research being done around this. We're kind of a bit of ahead of the curve, I guess, compared to the rest of the country.
Is your treatment methadone, Suboxone, Sublocade? What's the therapy?
Oh, what is that therapy? What do you mean?
The
Sorry.
medication. What
Those are-
what medications are they dispensing for, prescribing for
all
treatment?
three of those.
All three. Okay.
Yeah, you bet. And one of the biggest problems we find here is people staying on program because they have a hard time making it to their appointments and those kinds of things. So we've been able to kind of work to go to this outreach model where we can go find the clients, help them stay on program, and then also be able to just dial into a doc or a nurse practitioner immediately to have that follow-up appointment done to continue them to stay on dosage. So that's like, that would be an example. And so then what would happen there is the relationships are so strong between our OAT nurses and the clients that then all the other conversations start up around immunization, around STBBI testing, around women's health outreach and birth control and all those pieces. We can then pull these folks in to get a lot of their other healthcare needs met kind of within our agency.
This sounds terrific, Dallas. Thank you so much. Is there, oh, Jen in the last, when we were talking to Elaine said, it was a little bit of a, what would you recommend to us? But, you know, I think what I was wondering is if you said, if we said, what would you add or what would you do differently or what would make this better? Do you have sort of a basic recommendations and or a dream list that you would also share with us? Like, here's what
Yes.
would be even better. Okay.
Yes, so what would be even better would be a fixed site.
Okay.
So a site that had a bathroom and water that wasn't in a water tank and a place where you could have a private room for a social worker or an RN to sit down with the clients when they need to talk, a place where we could draw blood there. So a little bit less of we have this spot and this spot and this spot that it could all kind of be together. And I would say even that consumption itself wouldn't need to be the priority of the spot, if that makes sense. So the amount of other impact that we have other than supervised consumption, I would say some of the other pieces are actually higher impact. So the majority of folks that come and use on site, they're not the ones most likely to overdose. So what happens is our team ends up running outside all the time anyways, to serve overdoses that are outside. One of the key reasons for that is we don't have the ability for folks to smoke their drugs. And smoking is really, really popular as opposed to injection. So.
Really helpful.
Yeah.
I'd love to open it up to the working group members and see if anyone has other questions or thoughts for Dallas. We have Dallas, just a time check. We have Dallas until 3, our time.
Oh, no, you don't.
Yeah.
I think I'll just reinstate, you had Elaine here, so you've heard a lot of the ins and outs of all of this already. She's the master, certainly as far as advocacy for the clients and stuff in our province. I just think the key is that whatever solution you decide to try, that it has to be from that community development point where you're really talking to the neighbors and the stakeholders and the clients that you think are going to use the site, to see if there's buy-in before you do much investing. And the other piece is that relationship development is key to any of this working. And we've just learned that over the years, that without a relationship, you can't even, it's really hard to get a blood test, let alone get somebody to talk to you about their drug use. So yeah, relationship building is imperative.
Thank you, Dallas. I wonder, Rick, I think I'm looking at you because I thought you asked a really helpful question from Hugo regarding safety, and I wonder if you had a similar question for Dallas or something related.
Yeah, again, I mean, we're obviously, with your mobile site being, just curious about your hours of operation, and if you do have issues around, I'm assuming you have a great relationship with your local law enforcement to be able to kind of navigate this. Can you talk a little bit about your safety and security issues?
Sure. So we are not 24/7 like some of the other spots in the country. We are open 10 till 10. So 10 a.m. to 2200 every day, 7 days a week. I think that the order of safety and security is an amazing relationships with the clients. Most of them, it's kind of like, when you live in the neighborhood, but everybody knows you kind of thing. So we do have a ton of compassion and care from our clients who would all probably defend us kind of to the death. But we do have a good relationship with local law enforcement. So we are RCMP, Royal Canadian Mounted Police right now, which is our federal police force. Over the next couple of years, it will move to a city-driven police force, which is a little different. But it started once the plan was in place, a lot of engagement with RCMP, telling them what we're about, what the plan was, what their role is. And then we actually came up with protocols as to when we would call them versus when we wouldn't, how they could support us, how they could make it safe for the clients to come, because most of our clients are extremely triggered by law enforcement and scared of them or hate them. And so just working out how to have them be far enough away that they weren't a detriment to the clients coming to access services, but at our beck and call when we needed them. So we do quarterly education with all the new recruits, letting them know what we're all about. And usually as soon as they start hearing that list and those wraparound services and all the other things we're doing, they're like, okay, how can we help? Now we know who to call, say if we've got a young woman who's pregnant and homeless, so it just became about education was the key with the RCMP. But yeah, we have a good relationship with them, and there have been issues in the past, but we've worked through them. Yeah.
Thank you very much, Dallas.
Yeah.
Dina, I saw your hand up.
Yeah, hi Dallas. I perked up when you were describing the size and kind of nature of Grand Prairie, because it sounds a lot like Portland. I'm the assistant city manager of that city. I was curious about what your relationship, you talked a little bit about your relationship with law enforcement, but what it's like with city government in general, and also curious about the shelter you mentioned. Wanted to know if that was privately or publicly operated.
Okay, yeah, good question. So I'll maybe just go in reverse so I can try and remember. So the shelter is its own association, but does run on mostly provincial grants and some municipal grants. Maybe a federal one, I can't remember, but it's publicly and donation-based supported, I guess. We have a really good relationship with them because we serve a lot of the same folks. So that's part of that. What else did you ask? Oh, the city.
Just curious about, yeah.
Okay, so it's kind of all over the place, that relationship. They're our greatest allies for the most part. We are becoming more polarized than we've ever experienced. It's not generally something that people in the past would have thought kind of about Alberta or Western Canada, but politically we're getting quite polarized. So I've noticed as that's happened and we've had some swings, that our local government has maybe become a little bit more polarized in some of these issues as well. So it's a lot to do with language. So we don't, harm reduction kind of used to be the catchphrase, like the buzzword kind of thing. It was the word everybody wanted to use, but right now that's not super popular in Alberta. based on the government we have. So we've moved more towards health promotion, injury prevention kind of language, and that seems to be something people can really resonate with. I think there's a real hope by City Council that once there's more opportunity for recovery, the public drug use problem will go away. We know that's unlikely, unfortunately, because recovery facilities tend to not work well for people experiencing severe mental health and homelessness, right? Like it's not we don't have a model yet that works really well for that population. So like the city of Grand Prairie, when I wanted to move to a more permanent site, they were like, don't even ask, it's not going to go anywhere. But they're not in any way trying to get rid of the services we're giving. They're really aware that public disorder will increase, not decrease with the lack of us there.
Thank you. That helps. I appreciate your candor.
Okay.
Thank you, Dina and Dallas. Other questions for Dallas?
We don't know anything about polarization, Dallas. We're so surprised to hear that. That's all new to us down here.
Yeah.
I'm afraid that we've infected you a little bit up there, and that's sad to hear.
Like I said to Carol, we're all just people living where we live, right? And
Yeah.
there can be no
Yeah.
shame or apology for things that we're not in control of. So yeah,
We're just trying to help people. But
that's right.
but this has been very, very helpful. And we kind of get it now why it's mobile and and yet it's likely pretty permanent. So I really appreciate everything you've said, and the smoking piece is really important. We've heard a lot about that today, and yet likely your mobile structure just can't accommodate that.
No, it really can't. Yeah, and I do think the key is to try and put a whole bunch of services together. It's more palatable. It's more palatable for the public. It's more palatable like politically to be able to say, yes, we're also trying to treat this addiction and we're also trying to do this so that it becomes a real kind of hub for folks that are marginalized.
Well, it's the integrated model that we talked to Elaine about, that
Yeah.
rather than have it freestanding, where it's subject to attack, as harm reduction, if it can be part of a health center. And this is simply part of our health services that we provide. I think we get that. Dina, you've got your hand up.
I had one more question. You mentioned there being about around 300, I think, unhoused people. I didn't know if that included both those who were in emergency shelters and sleeping rough, or what that actual number is.
It would be about the count that accesses the shelter. So the folks that sleep rough are hard to count.
Yeah.
So yeah, and those are unofficial numbers.
Yeah.
Haven't been released, just so you know.
Okay.
But
Sure.
yeah, but they would be pretty spot on.
Okay, thanks.
Yeah.
What's the capacity of the shelter, Alice?
Oh, way smaller than that. So I don't even know what it would be, but they've been over capacity forever. So they do have another spot kind of across the street that they could put mats down in at night. Especially when we ended up with like the cold front that we had here this past week. So that even band folks can access shelter when it's that cold. So.
To that credit, Dina City opened in the last year a shelter that has 260 or more, Dina. And it's pretty fantastic, frankly, from what I can see as a layperson. Anything else, Carol?
No, just a big thank you, Dallas, for all of your time today and your time yesterday to chat with me. And again, just engaging last minute, all things considered, into helping us. So we just really, really appreciate it.
Yeah, thank you so much. And Carol, just feel free to share my email with everybody so that, yeah, you can always
great.
email me if you have questions or anything. And we have lots of resources if you get to that point where you need them or help in any way.
Amazing.
Okay.
Thank you again.
It was a pleasure. Take care, everyone.
Yeah, you too.
Bye.
Excellent. So those were three, that was a lot of content, obviously, but really, really interesting. What Gordon and I had kind of imagined when we hatched this scheme was that we'd take about 15 minutes and maybe just do some debrief while it's fresh-ish in all of our minds and not all jumbled together. I wonder if folks, for anyone who can stay, and we appreciate again any working group members who can stay on, but if you can stay and you have time to sort of go, reflections. So thinking about Hugo, Elaine, and Dallas, what should we be capturing in terms of takeaways? Or just things that you thought, hey, I thought I was going to hear one thing and it turned out to be something else. I mean, anything you'd like to toss into the mix.
I heard a lot more about inhalation and how important that piece was, which I also heard in Providence. We've not necessarily seen as much movement towards smoking, I don't think, as they have in Portugal and Canada, but we've seen some, and likely that is a growing trend. So if there were to be such a site, we want to make sure that that's accommodated.
Yeah. And Gordon, I think it was the meeting that you missed, but the Vermont, our colleague from Vermont flagged that they actually spent a lot of time trying to figure out how to do the ventilation so that they could make sure that the inhalation option was available for their new site in Burlington.
I did watch the tape of them.
Oh, great. Okay. Yeah. So I think we should definitely follow up with Vermont as we pursue this. Jen, I see your hand.
Hi. I think just some of the themes that jumped out to me as to consider in the final report is I really appreciated that brief conversation around setting expectations, particularly when it comes to measurement. And I think, in my public health mind, I like logic model it out. Like, what are the recommendations on measuring success? I thought it was very important. I thought what I heard that really stuck with me is if it's going to be measured by, the reduction in whatever that looks like, that can be unrealistic to set as an expectation for a measure, particularly right at the start. So I thought that was really helpful for me to hear what are the recommendations on measuring effectiveness and success. And then the other thing that I heard, as I probably already mentioned, is this idea of overall community involvement, and that these centers were actually in some ways uplifting the community, and that information for how a center can have impact, and this goes maybe back to expectations, that I think what was clearly stated, like that measurement can actually happen beforehand. And so those were things that really jumped out to me that I had not heard kind of before with other presentations that I think were really kind of nuggets for including in the final report. And the last thing that I'll mention is, I've often been sitting here with my public health hat on and my municipal staff person hat on, and this could be a tricky place to be. And I think in one of the presentations we heard about how the city, they had a very specific role in gathering community conversation, in participating in how the community was going to invest, recognize whatever that looked like. And I think I'm curious what Dina would think as well, as we go into this report and we think about what are the overarching suggestions, thoughts, recommendations, however we want to put that for municipalities, we can expand on what are the options for how municipalities can be involved in this process.
Love that.
Not just a yes, no.
Right, right. Yep. Thank you, Jen. Really appreciate your thoughts on that. Jeff?
Just similar to what Jen said, and it looks like Mr. Desjardins has left, but I think if we're thinking about things to include in the report, his questions about violence were answered by the presenters, and that it's not a 0% chance of happening. There is violence, but that working with those, like that relationship building was how these programs have dealt with that. I think it's an important thing to include in our report.
Well, also, Jeff, in Hugo's case, there's so little risk of violence in the Portugal site that they don't even have security. But I want to offer about 3 quick things. One, that few minutes with this Elaine was just fantastic, I thought, and particularly on the issue of population level impact. That is what I've been talking about. That's what I've talked about Brandon Marshall about, is that because I've been aware that nobody's been able to show me that this population impact where these sites exist. In other words, that there's actually been a decline in the population level overdoses. We all understand the data that nobody dies in the sites. Great. But I want to know, are they dying, the next day back in their shelter or apartment? And I kind of got an answer to that today. We won't be able to see that, that this is not the purpose of these sites, and that we're unlikely to see population level impact. And from a lane standpoint, that's okay. So that was important for me to hear, and because not many people are talking about that. The setting expectations, absolutely, and we should make that clear. The relationship with the homelessness, with homeless, forget which of the presentations made that point so vividly, that people, because of the shame and stigma, that most people that have a place to use are going to use that place. They're not going to go to a freestanding place, but it will be really might be utilized by people who are using outdoors, using in public places, have no home. That's really important for us to know. And the fact that, I don't know how we get at this. When I'm in Rhode Island Wednesday, I'm going to ask them about it. It would be, we need to include people who are using drugs. This part of that segment who don't and not have any intention of seeking treatment anytime soon, whether they would use such a site. If this was available to you in your community, would you use it? I don't know. Tess might know, our advocates might know, but it would be important to ask that question if we can of that population. So that's all I have to offer.
Thank you, Gordon. I wonder if folks had more thoughts. When Gordon mentioned the freestanding and I was struck by the integrated, the many people who talked about the integrated model, and obviously Dallas put a fine point on that at the very tail end, which is that the integrated model works really, really well because you're logically taking this where people already are going. But did folks, I remember, and Gordon, maybe this is for you, but when we talked with the Health Canada, the woman from Health Canada, she said creating a chill space. I remember her, it was something like the creation of the chill space is one of the most important design factors in the model, because if you're integrating, you want to have a little almost like a neutral zone or chill space, so that people feel like they are just, it's just part of their experience of going wherever they're going. She actually used a pharmacy example of these are being integrated into pharmacies, but with a chill space between the door of the farm, you know, you go in the pharmacy, you're doing whatever you're doing, and then you have another door you go through and yet a second door. I just wondered if how you folks are thinking about this whole integrated model versus non-integrated based on everything we heard. And Jason, feel free to talk about something else, but that jumped out at me.
No, this is right on track. I mean, I think our SSP in the last 2 weeks has turned a corner in developing those relationships with really getting in deep with people who are using in the Bangor area. And I think that is, I mean, I've been working a lot with Jen and with other providers to talk about how we do that better and how we do that more holistically in connecting people to care. And it has to be all of these connections together. I mean, we're seeing such great work across all of us who are doing this. I think, you know, getting people connected to care, you know, people are not necessarily, they're coming in every other day to get their needles, but they're also coming in to pick up a food, or, you know, they're coming in to get a pair of mittens that we have, and then they sit down and talk, and we have a few minutes to say, oh, have you had an HIV test? And they're like, not today, but maybe tomorrow I'll come in and do that. And we're like, okay, we'll be right here. And, you know, it's taken, you know, in the last 2 weeks, we really turned that corner, and we see people every other day who who we're able to make some progress with. So I just think that is a good, yes, everything we learned today has reinforced what I've been experiencing in the last 2 weeks. And I think that we can build off that model. I think our SSPs around the state are a good place to talk about how that integration already happens and the progress that is happening around the state with that model. So
That's really great news, Jason. Thanks for sharing that and the connections there. Other thoughts, reflections, anything that popped out to you, either surprises or reinforcements of what you've been already thinking? Okay. Well, then I would say, Gordon, if you are in agreement, I think we should probably then keep moving. We're marching our way towards 3:30 as a final adjournment here. So just making sure we fit things in. I wanted to just cross-check our game plan, which is, let's call it a fast pace from here to next Friday. We have next Friday set aside from 1:30 to 3:30, and I know not everyone can join, but the idea is that we put something before you in writing, which is a combination of all the good content that Tess produced, some content that we already actually had from some of our actual members, you know, Jeff's paper. Gordon has consolidated some of the federal issues into a few paragraphs. And we zero in on kind of the, you know, again, who are we? What are we doing here? What's the background situation? What was our methodology? What are our findings? And what can we recommend or share with the committee? The idea was that we would have sort of a final discussion next week on Friday, and then all of you would have a couple weeks to take what we've come up with and turn it around with your colleagues, constituents, stakeholders, so that by the end of the month, we would be turning it over to the committee. And unless you all tell me something I haven't heard yet, I think that is the plan. So I'm just curious if anybody is thinking about this in a different way, or if anything has changed in your calculation of how we get from here to there. Okay, so that is the game plan then, which is 1:30 to 3:30 next Friday. We will have a conversation. Gordon and I are going to basically work diligently between now and then to produce a draft. We'll make adjustments after your edits. I think we should create a means for you to provide edits even before that meeting, and also knowing that not all of you can make the meeting. A means for you to provide comments or specific edits. And then the idea would be by the following Monday or Tuesday, we would turn that back to you for, please share this with your teams, your communities. Does that make sense?
We should talk about too, whether we do have an offer for a presentation on the 14th from Quebec, the province of Quebec, the health ministry there. I'm thinking that we really should commit all the 14th to our drafting and review and discussion. And that I think Carol and I will meet with the ministry in Quebec, learn as much as we can, because those sites are closer to Maine, it turns out, than even the Atlantic provinces. And they've offered, and like I say, they have a really robust program in Montreal, for instance. So I think, Carol, you and I could do that anytime in the next couple of weeks. But that we should reserve the 2 hours next week for discussion. While this might seem impossible to you that we could do this report this quickly, remember that a good third of this report is going to be the statute, the resolve, the members, and our meetings. And we'll list the meetings, who we heard from, what the topics were that meeting. And then I've drafted a piece that I think would be relatively not uncontroversial regarding the federal law. I drew that right from Jeff's law review article in his presentation. And I again, not putting words in your mouth, you'll get to review this. It's now in our Google documents, maybe, or it's going to be shortly. My conclusion was that it's just unsettled. The law is unsettled at this point, and until we've not yet heard from the new Justice Department. And I do that in about 620 words. And there might be other sections that we could send you even before next week. I think what you're going to really be robustly discussing is, a few paragraphs in there about, our findings and recommendations. And that's what we should reserve that discussion for. And I'll be, as the chair, looking for areas of agreement, things that we can say that we reach consensus on, and not focus on things that we're never going to have agreement on. But you get to decide, your document. You get to decide what we do about those areas. I'd like to, I've never found it particularly helpful to have a majority and minority report, for instance, but in this type of thing. But again, these are things we talk about next week, and I appreciate all the time that everybody's putting on. And again, we're not under enormous pressure. The legislature's busy. They've given us till the end of the month. We're going to move this as fast as we can. And then again, I remind you, they're going to have the opportunity to say whether they'd like to have us continue to work on this, and let them know in December what's happened in Providence, what's happened in Burlington, whether we've heard from the Justice Department, or whether they want to take this report as a final report and decide whether to report out a bill or not. That's their decision, not our decision. But I'm going to make it clear that that's, in my opinion, the majority of us are willing to do that additional work and find resources to hopefully have Carol help us if that's their wishes. I know that's disappointing to some of you, and I appreciate that. But again, having spent 45 years over there, I really do have kind of a pathway in mind that's likely I can see where this is going to go. When you've got a committee that has really polarized members already, on most issues involving criminal justice and public safety. They're not going to quickly arrive at a consensus on this issue. And that being the case, they would love to have us continue to provide data to them on, okay, what did this really look like after Providence opened? What did Burlington look like? Has the Trump administration weighed in on this? Rather than to right now report out a bill. It's partly human nature that they don't like to make hard decisions, and anything that they can put off into the next session, they will. And this is going to be a very difficult session for this legislature. You heard about that last week. We thought we had an agreement on the supplemental budget, thought we wouldn't have to cap Medicaid payments. Everything was set. No, one person wasn't there. And now we don't have agreement on the supplemental, which means that you can't have access to that money for 90 days, which means that we can't pay our Medicaid bill in full. So I'm not saying tonight you could watch the news and find that, okay, that's back on track. But all I'm saying that it's a tough time over there. And I think something as interesting and intellectually challenging as this, that they would welcome the chance for us to continue our work if you're willing. But we'll get into this more next week.
Great.
Carol, what else do we need from them today?
This would be the final 9 minutes here. Would be any additional comments or feedback the working group members would like to make. Otherwise, we can adjourn a bit early and let you all begin your plans for snowy adventures.
Particularly if there's any areas that you'd like Carol and I over the next week to spend more time on, get another presentation on, or any questions you want us to ask of any of the presenters, anything like that.
So I said this earlier.
Jen.
Sorry, Jen.
Quick with my hand here. I don't know. I forget who's representing law enforcement, but we haven't heard from law enforcement from their perspective where there is a harm reduction health center. So I'm wondering, I feel like that's the piece that I haven't heard the voice of. So
you mean
if there was a voice to hear, I think that's one that I'm missing.
Yeah, we'll give that some thought. So you mean, I thought you meant the 3 law enforcement people on our work group, because they did kind of weigh in 2 meetings ago. But you're talking about law enforcement, public safety people in a community that we've heard from that has a site.
Okay, now I want to say both. So
Okay.
I think it would be helpful to have someone come and talk about, from law enforcement, to talk about what it's like to have a harm reduction health center in their community. And in that, hear from our representatives of law enforcement, their thoughts on that presentation. I feel like I'm just missing a little bit of that.
Yeah, that makes sense, Jen. And the loss of Rick here this afternoon is too bad, but it would be great. Maybe Gordon, you and I can try to pin Rick down to get his feedback. And I know he missed the last segment, but
well, he and Scott and both Scotts, and I think the 2 Scotts really feel that they represent all the sheriffs and all the police chiefs, that they speak for their association. In my experience around, we'll have to think about I've heard the New York City Police Department talk about On Point. I've been with the public safety people in Providence. I mean, the only reason that these places work is because they have the support of law enforcement. So I think you'd find quite a lot of support by public safety in those communities. And I don't know whether the impact that would have on Scott and Rick, but yeah, we'll see where we'll talk to them about what might be helpful in that regard. Maybe I can even get some help when I'm in Rhode Island on Wednesday. You know, it's good.
And I wonder about Edmonton. You know, they've been doing this longer than
Mhm.
any other North American city anyway. I don't mind following back up with Elaine and asking if she has a contact in their law enforcement agency.
Well, and I'll also talk to Commissioner Sostrak because he is really my liaison to the public safety community. And he attends the meetings of the, obviously has direct control over the state police, but he also attends the meetings of the sheriffs and the chiefs of police. And having been the former police chief in Portland, you know, he has great credibility with me, and maybe he can help. He has good relationships around the country. Maybe he can help sort out, well, what would be the best presentation on the public safety aspect of this? Because otherwise, I'll be honest, I mean, I just anticipate that the three people representing public safety are just going to say, no, we haven't been moved by any of the presentations to the point where we think this is a good idea in Maine. I mean, I'm just telling you that's what I would expect. I'm not disrespecting them or disrespecting you. I mean, Jonathan, you work with these people as a district attorney. I mean, isn't that what you would expect?
Yes, I think Gordon, that's accurate, and I don't think if any of them were there, I would be afraid to say that as well and let them correct me if I'm wrong. But no, I think that's a valid assessment.
Yeah, but but we can certainly be responsive, Jen, to your request that we hear from some public safety people around some of the sites. I tend to think it ought to
Yeah,
be
if
in
it's
this
not the
country.
consensus of others, that's fine. I can do my own reading.
No,
But that was just something I wanted to throw out there in case
I do
others
think-
felt the same.
I think it'd be more valuable from Providence or New York City, though, I'll be honest with you, or even Burlington, because Canada they're just, you know, look, they have 90 sites, you know, and we've had these sites around the world for 40 years. We have 3, you know, and they've been somewhat successful, in my opinion. I mean, it was disappointing to hear that they're also becoming more polarized. And I had read an article that somebody was trying to shut down all the sites in Alberta. But I think that they simply are like Portugal, like Hugo. They've done a better job than we have in this country of viewing this issue as a health issue and as a public health issue than a law enforcement issue. Jason.
Thank you. No, I think this boils down to a difference in culture. And I use the word culture in a very broad-based aspect here, but even just listening to the way that people in Canada talk about the services and the humanity that they use in their language is so very different than we do here. And I just want to acknowledge that. Like, I don't know how we overcome that in this process, but I think it's important for us to state in this that there is the rest of the world has a different culture around this than we do. And until we address that, we're gonna keep running into this, you know. And
Yep.
so
Well,
thank
not
you.
necessarily the whole rest of the world. There are places that just execute people with drugs. So, I mean, what I would say is that there are absolutely places that we've talked to, that we've heard from,
Yeah.
that have a much different approach that seems to be successful in keeping people alive. They have way fewer overdoses, fatal in Portugal per capita and in Canada than we do,
Thank you for
including
the clarification.
including in Maine. But there are places in the world that still not even where we are yet. All
Gordon,
right,
Jeff
well,
had his hand up as well.
Yeah, Jeff.
Oh, I was gonna say the same thing as Jen, and then she just said getting law enforcement perspectives. I think is important. I agree with Gordon and Jonathan that we're probably not going to change hearts and minds. But if the report could at least say we reached out to law enforcement in the areas where this existed, and these were their experiences, especially the story we heard today of law enforcement that initially wasn't supportive, but through seeing it in action, it seems like their minds were changed. I think that's really important to share with the legislature.
Thanks, Jeff. I do wonder if maybe my idea initially of Elaine is actually trumped by the Dallas Grand Prairie, which seems much more similar to the culture of Maine than perhaps Edmonton. I'll follow up with Dallas.
Dr. Benowitz, you get the last word because we got a hard stop here at 3:30.
Thanks. Just a quick question as the clock hits 3:30. This was super interesting. Really appreciate listening in. I think I heard the woman from Canada say that she was part of a delegation that came to the US, and I didn't get the full scope of what that group was or where they visited or who invited them, but it might be helpful if we haven't already to find out who organized that and whether there's someone at the national level, maybe someone who just left federal service, who might be willing to talk to us about what they were looking for and what they learned.
It'd be great. Yeah, we know
Idea.
we know that she got to Concord, New Hampshire.
Yeah,
so,
she got to
yeah,
Concord. That's all
we'll
we got.
ask what that was. We'll talk to Elaine and ask what that was about. So anyway, I just appreciate all your time. I know how busy you all are, and we're going to be at it again next Friday. So thanks for hanging in there, and communicate privately or otherwise with us. And we'll see you next Friday. Have a great weekend.
Thanks
Gordon or
all.
Carol, can you just stay on for 1 second, or did we just?
Oh yeah. Hey, Jonathan.
Carol, the only suggestion I was gonna make if you reach out to somebody from law enforcement is to sort of ask not just what their views are on the subject, but what the effect is around the surrounding areas. Because I think that's a concern that law enforcement has about whether or not there's going to be increased theft crime or nuisance crimes, or they're gonna get more calls for service because the stigma that goes along with these areas. And so that's where I think there's a lot of where law enforcement has concerns. It's not so much in the idea of safe injection sites or harm reduction sites, whatever we're going to call them, but sort of what those collateral consequences that come along with it are. Because I think, and I don't quite remember, I forget exactly which, if it was Scott or if it was one of the other, anyway, but there was an article about how like property crimes went up like 1,000% in one of these areas or something like that. And so I think that's where a lot of those concerns come. So if you do reach out to those local law enforcement, please ask those questions too, because I think that that's going to be important for other law enforcement to hear. So